James. So today we have an important topic, rehabilitation in palliative care. And I think we would not get any other best person other than Nandakumar sir to take this topic. So Dr. Nandakumar is a retired professor of physiatry from Government Medical College, Trivandrum. And he has extensive experience with patients who is in palliative care. And he has a lot of experience in working with different types of patients and in rehabilitating them. So he has been closely collaborating with us for rehabilitation and pain management. At present, he is working as the consultant in Travancore Medicity. And I welcome you, sir, for your presentation, and it's over to you.
Okay, thank you so much for the nice words that you said. My topic today is rehabilitation in palliative care. I suppose I'm audible. If somebody can just comment on my audibility.
Yes, sir, it's audible here, but I would like whether all of you are, is it okay for you?
Yes, sir, it is audible.
Okay, thank you.
So, before I start sharing my screen, I will just say what is rehabilitation about. I'm sure this crowd, the participants here knows very well what rehabilitation is, and I need not spend a lot of time on it. However, just to make sure that it is also covered, I'm just saying a few words about rehabilitation. Fundamentally, on the outset, rehabilitation and palliative medicine might look a lot similar, but there is indeed one small difference in the approaches to both type of care. In rehabilitative care, we focus on trying to improve the quality of life of the client. Whatever be the situation, whatever be this client's situation, we try to improve the quality of life, at least by a degree. Now, when I say improving the quality of life, it's a little difficult to say for sure how the quality of life can be understood. It should be understood from the point of view of the client. It's the client who describes what sort of change he or she wants in the life. And as a rehabilitation professional or any person working in the rehabilitation team should try to put that into practice. Not my knowledge of how a higher quality of life is accessible to a person with disability or in need of palliation. So imagine a person who is lying down with malignancy, or a senior citizen who is slowly becoming more and more disabled. Now, how do you plan to improve the quality of life? I presume that the quality of life features should come from the client himself or herself. And as a professional, it's our duty to plan it in such a way that it makes meaning for that person. He may not achieve, or she may not achieve it, but he or she should understand what it means. He or she should get the meaning of it. And then they may try to do it and fail, or they may try to do it and then partially be successful. That's good. It's good enough. Now, the second point is, because these are the steps in rehabilitation, the other important consideration in rehabilitation is that we should also be seen as an educative process. It's not simply a prescriptive process. In other words, if you write down a prescription, the rehabilitation does not begin or end there. It has to be a series of processes which ultimately links the client's brain into it, client's thinking into it. So it's a sort of a cognitive process. That's what makes rehabilitation important. That's perhaps one difference from the palliative care that we might think of. However, in many diseases, both should stand together. You cannot say where rehabilitation ends or palliation begins, or vice versa. Both are simultaneously required. So this is how I would see rehabilitation. And the traditional definition of rehabilitation that many of you must have heard is the ability to put the person into the highest level of mental, physical, or social ability. Is a sort of a Second World War ideal sort of definition, which it's difficult because no person can be improved to the best of his or her ability unless he or she wants it. So I may have lots of abilities, I may have lots of inabilities. That doesn't mean that I would take all my abilities and live, or I would dodge all my disabilities and go on living. Life is not a simple task. It is not simple tasks like this. Life is much more complex, even the daily life level. So that is why this is a small, little by little, you go on changing. And when you say it's an educational process, it's a cognitive process, it also means that the rehabilitationist is also learning with the client. So both the client and both of us share experiences and then try to improve our skills as we go on. So this will be the sort of introduction that I will give, and then I think I'll go to the slides. I shall. Can you see the slide?
Yes, sir, we can see, sir.
Okay. Is it okay or?
Sir, can you turn to presentation mode or slideshow, sir?
Yeah. Is it okay?
Yes, sir. Yes, sir. No, fine, sir.
Yeah. Now, this will be something like a typical patients that you would see. Now, if you look at this person, it's a young person. He has a lot of life in him, but then if you look carefully, he has a major problem in his body. Both his legs or lower limbs are paralyzed, and you can see the impact of consequence of paralysis. That his legs are thinned out, and his foot is in a state of deformity, and he is lying on a Macintosh or a rubber sheet or a sheet with the wrinkles and not very appropriately made. So this is the typical situation that many people with a disability or people who might require palliative care are seen in. So we need to look at life from his vision. That's what I was trying to say. Now, what are the rehabilitation needs? When you understand, when you look into rehabilitation as a technology for better quality life, we should know that a person sits in a sort of a soup of society with a lot of value systems. He or she understands value systems. We are all supported by certain value systems. We have to meet certain value systems. We also look at our own life in terms of quality. And we also look at our life in terms of competence and power. That's what makes us go forward. So any person who loses these becomes less and less of a person. So one of the greatest problems of people who require rehabilitation is that these people will have some compromise in these three facets of life. Either their value systems might be altered, or their perceptions of quality must be altered, maybe higher or lower, whatever. or the society must have carved into their competence and power. And it's a very important thing that we should know. Any person who has a disability or a problem in life which necessitates whether you're bedridden or whatever, he loses competence. Competence means your ability to understand yourself, your ability to take decisions for yourself, or the power to influence others. These are the things that you lose when you have a chronic disease. It need not be unconsciousness or paralysis or a stroke or even senior citizens lose this. Even a person at my age might lose some of these. I may not know about it, but at my age, I might lose a little bit. I may be able. I might be compromising on certain quality standards. I may be compromising on certain like competence and power. For example, my son or daughter will ask me to take the grandchild to the school, which I might find it difficult because I have a backache or I have a little brittle diabetes. I might find it difficult. But then when my daughter or my son says, you have to take this child to school, or you have to take go to the shop and get vegetables for cooking, then I cannot resist them, in spite of the fact that I may still be earning. I may be earning member, I may still have financially competent, but then within the house, I lose a little bit of power. So this sort of losing power is the hallmark of the need for rehabilitation. So rehabilitation addresses these things, should address these things. It's not enough if you simply say it is a function of disease. No, any disease, any chronic disease, even if it's diabetes, it impacts upon a person's competence and power. The moment you do that, that person is in a state of disability, and that person requires some sort of rehabilitation. Now, it's all very easy to say that. Perhaps it's also very easy for me to understand that I have lost a little bit of quality. I am actually struggling to make my value system in life. I might have lost a little bit of power in my life. Yeah, you tell me, I understand that. But then, how do I change? It's very difficult to change when you're in a particular situation. And then that is where the professional comes in. The professional has to discuss with me, start talking to me, and then he or she, the professional, should understand what my needs are, where my needs are compromised, and then what is it that I would want immediately, and how slowly you can go it. You cannot simply say you go on changing it. You tell your daughter, you tell your son that you cannot take your grandchild to the school. It's not possible. You cannot. I cannot tell them, because the moment I see them, the moment I see the power, the moment I negotiate at the level of power, I immediately withdraw because I'm scared. Now you have to give me the confidence to slowly hasten. So you can have the speed, but just be very, very slow at my own level, the person's level. And you also have to find out what is the patient support system, because a professional will come, give advices and go. And then he or she is not seen anymore. The rehabilitation professionals, there may be several people, and they will come and talk to the patient, and then they leave. But the patient is still in the same environment. He has no escape. The patient does not have any escape. He still has to negotiate with the same environment. So therefore, understanding the support system is extremely important. And then you have to find out which support system can be used to enhance the client's rehabilitative need. So that is a very important part of assessment of any client with a rehabilitation need. Now, let's now think of how you can meet these needs. I suppose I'm making myself understandable, is it not? Is it okay? I can proceed, or?
Yes, sir. Yes, sir.
Okay. So in case there is any doubt or difference of opinion or need to clarify, you can just interrupt me. There's no problem. Yeah. Now, how do you meet the needs of a client who requires rehabilitation? Now, you should know how disability or a need for rehabilitation manifests itself. One of the most important thing that if I am completely disabled, in a state of disability, let us say it is cancer or a COPD, whatever, would be a return of movement. That would be the first concern. If only I could move my hand, if only I could get up and walk to the toilet, if only I can stand and perhaps lift my grandchild at least once. These are the small things that then you need a good quality body or a healthy skin. Then you need mobility, and then you need walking. Now, the fact that I need only movement at a particular level doesn't mean that I don't require walking at a later stage. That, in other words, when I achieve one aspect of it, let us say I don't have any movement. Suddenly you help me and I start getting movement. Immediately I would want another one. Let me say, at that point I will say, if only I had some mobility also. If only I could get out of my bed and go to the veranda and sit there and watch the birds and my dog going out. So such additional needs will come. So always one need gives rise to another need. It is so with all people, not only with the people who require rehabilitation. With everyone, it is like that. If you do not have a house, you need at least a house with a single room. If you have a one-bedroom house, you want two. If you have a two-bedroom house, you need three. It goes on like that. It's not. So the human needs are always increasing, and because this is also related to competence and establishing yourself in the world, these are very extremely important. So therefore, ultimately, from a trace of moment to a good skin. So a good skin is very extremely important for social positioning. So if my skin is wrinkled, ulcerated, it doesn't look good for the society, because it becomes a barrier for the society to come to terms with me. So therefore, we have all these things, a hierarchy of requirement. So finally, at the mechanical level, minimum mode of walking is extremely important. So it goes on like that. Okay. Another level, you have certain type of mental, social, or cognitive type of needs. So these are other set of needs. You can actually, these are also assessing tools. This can also be used as used to predict where you stand with respect to the client. Now, I will treat certain techniques for personal adaptation. Then you will have to test me whether I am compliant with whatever things we are discussing. You tell me something, I tell you something, finally we agree to do something, and then you will have to test whether I am complying with it. Now, compliance is a very important aspect of rehabilitation. Even in palliation, compliance is extremely important, because it's very, very difficult for people to comply with certain conditions. Now, if you look at compliance in medicine, if you look at ordinary, very simple compliance issues, like for example, treatment of hypertension, high BP. If you take 100 people in the rural area, go to any town in India, take 100 people with high BP and ask them, are you taking medications regularly, or are you having your hypertension controlled? You know that controlling hypertension is a very simple thing in the world. You take 1 tablet or 2 tablets, 3 tablets per day, hypertension is always controlled. But you will, interestingly, you will find that only about 50% of the people take medicines regularly, and only 50% of the people will have the hypertension under control. So this is a tragic situation in India. So you can see that. Similarly, diabetes is a disease that all of us know. It's a problem that everybody knows. Everybody knows that diabetes is a problem with the sugar metabolism. Diabetes can be controlled. One of the methods of control of diabetes is to eat less and less of sugar and starch. So modify your food, then have a certain amount of behavioral changes, then supplement it with medication. So 3-pronged strategy, very clear. There's absolutely no problem with it. You ask anybody, they will know. But look at the number of people who have diabetes under control. You go to any place and ask people, are you a diabetic? Yes, I am a diabetic. Are you having it controlled? Yes, I am under control. What is your blood sugar? 220. So that's what they will say, because they never control. They do not understand what control means. So compliance is not a simple thing. Compliance is a highly complex thing, because compliance perhaps is a function of brain, because many people, highly educated people who are professors, doctors, engineers, advocates, they do not comply. They do not control their diabetes. You go to any place, irrespective of the people, you take 100 people with diabetes, 50 will be out of control, will not have any control. They wouldn't be even checking. They wouldn't be checking the blood sugar level. They wouldn't be checking the HbA1c level. They would be taking a lot of starch, and they would not be taking sufficient amount of protein. It goes on like that. And they will also claim that they are under control. So compliance is an extremely tricky word, and it's really extremely important to understand what compliance means. Yeah. The other thing that is very important as far as from the rehabilitation point of view is sexuality. Now, what is sexuality? Sexuality, if you understand sexuality from the point of view of rehabilitation, it is not merely the sexual act between two people. No, that's not it. Now, all of us are sexual, whether you indulge in a sexual relationship or not. For example, I always say that even Mother Teresa is a sexual person. Even the Pope is a sexual person, because it is this sexual being in me that expresses myself before you. So that is sexuality. Sexuality is not about being male or female. It's also about that, of course, but then sexuality is a sort of a positioning in society. How do I position myself in society? So that is why even there was a time when hysterectomies were very popular. Women didn't, even postmenopausal women would like to do the hysterectomy because they feel that they lose something. That's about sexual function. It's not about the sexual act. Sexuality gives you identity. It's an extremely important thing that you should know. And when people are in a state of disability, they lose sexuality because the carers do not care about them. They remove their dress in public. They put the catheter. They remove the catheter. They comment about the sexual organ. They don't treat you as a full person. So sexuality is also about power, because how do you position yourself? It's extremely important. It's a very sensitive thing. And unfortunately, we are unable to connect sexuality with the way we live. Our living life and sexuality are quite often not connected. Instead, quite often even professionals think of sexuality as a feature of reproduction or things like that, which is not, which is only part of it. Yeah. So please understand sexuality from that point of view. Then you understand rehabilitation better. Now, the next is about power. Every person lives in a universe of. I live in my universe, and in my universe, I feel that I am the most powerful person. Even the prime minister, or the chief minister, or the president is less powerful than me. That's the way I think of myself. Of course, I know I am wrong, but that's the way I think. So within my universe, I think I am very competent and powerful. So in persons with a rehabilitative need, this power is dismantled. You have to renegotiate this power. So giving back this power is an extremely important thing. And with all these things is the autonomy. Autonomy is your ability to look after yourself, take decisions for yourself, face the tomorrow that you have. So the autonomy, maintaining the autonomy or achieving the autonomy is perhaps the highest level of rehabilitation. Now, going back, these are the two triangles that I showed. If you can find a person who requires rehabilitation and run through this sort of a thing, then you have made a good assessment of what rehabilitation needs are. And you can place the rehabilitation need in a particular level and then start thinking and finding out where you can intervene. You may not be able to intervene in all places. No, may not be possible because the client may not want it and client may be very sensitive about it. So whatever is possible, you try to get involved. And wherever is possible, try to quantify it and then make tabular columns by dates and say that this is what I have achieved today, and make a goal for 2 weeks or 1 week or 2 weeks, and this is what I would achieve. Discuss with the client and then settle it and then plan it forward. So that's how you do it. Now, the other thing is in discussion. I'm just putting across you a very interesting study which came in Annals of Medicine in 1984. When patients talk to doctors interrupt them in the first 18 seconds. So this is an important thing that you should, all of us should remember. So unless you listen to people, you don't get to do rehabilitation. I don't know about the clinical medicine. So maybe somebody who has a myocardial infarction, you can talk and you can ask the patient to shut down, maybe. But in rehabilitation, patients conversation with the patient or enabling the patient to talk itself is an empowering thing to do. And you need to go on listening to the patients. The studies have shown that in the first 18 seconds, doctors interrupted. It's really not only doctors, it's all health professionals put together. They interrupt the client, the client in the first 18 seconds. But this study was done long time ago. So of course, there's a problem with the study because the study was done in 1984. So maybe are things better now? Yeah, the study has been done, repeated in 2002, and it came in British Medical Journal. And what did that study find? Now 18 seconds have become 22 seconds. That's all. So that's all. So we need to know how to listen to people. How to listen to people. So this type of a listening, a critical listening, it's not simply listening to any garbage. No, it is about a sort of a critical listening. This listening is extremely important because only this listening will actually tell you how pick up points where you can actually sort of intervene. Okay. Now rehabilitation can be considered from 2 points of view. You can consider rehabilitation the individual point of view. You can also consider rehabilitation a community service. Of course, what community-based rehabilitation is a different subject altogether. I'm not going into that. But you try to, in most of the community level service, you try to restore the individual to their pre-injury level or pre-illness level or health, if it is possible. Now, for that, you need to have some association with the social, vocational agencies around in the community. Unless they come in, it's very, very difficult to do that sort of a rehabilitation. And therefore, such rehabilitative strategies are human resource intensive. You need intensive and trained human resources, because only these people can actually volunteer to come together and do a rehabilitation service. Because when you think of community rehabilitation services, there are many community rehabilitation services in India, in many places. Most of them are unsustainable because they operate for a period of time, maybe 1 year, 2 years, and then they disappear. Those are not the typical rehabilitation services. It needs to be sustained over a period of time. And then after sustaining over a period of time, perhaps the same community can take over it. The critical skills can be transferred, and the community can become competent and take over and start it once again. So such things do not happen in India. So we do not at present have a real community rehabilitation service. Now, of course, with whatever we have, you have a rehab professionals, irrespective of the background training. You can be a physician or a therapist or whatever, social scientist or educator. Anybody can be a rehabilitative person. So rehabilitation professionals need not have a specific qualification, specific type of training. Whatever be the type of training, you offer what you have, and then you bring other skills together into that. And then anyway, that person has to, but then that person will have to know how to wear different types of hats, different type of thinking hats. So if you have 6 thinking hat, then you become a better rehabilitationist than a person who has only 2 thinking hats. So it's only hatting how many hats you have. So he or she should have should be a sort of an educator, a coach, because in the educative process you have to be like that, and then you have to be a leader and a collaborator, because many of the time the person's requirement will be different from the family and the person may be fighting not in front of you, but once you leave they will be fighting against each other. So you have to find the little bit of conflict that occur between the person who requires rehabilitation and the family, and then you will have to manage that. These are the very critical skills that people should have. Now, one of the important aspects of rehabilitation, basic things will be to make the people do some exercise. And that also is not, I just mentioned the story of hypertension and diabetes. Similarly, doing exercise is also extremely difficult. Nobody does it. If possible, nobody will do it. Why do people do not do exercise or do not like to do exercise? They will have a set of answers for that. there are negative exercises. When I exercised last week, I had a syncope and then I fell down and I had to go to the hospital. Or I am not confident about the exercise that you are prescribing me. You are saying you walk for some time, or you dance, or you climb stairs. But I am not confident in doing that. Or I do not have the knowledge. Suppose you prescribe me yoga or things like that. I don't have the knowledge, or I don't have the experience to do that. Or then if you ask me to go out to the playground and do something, then I have a social physique anxiety. Or I will say I don't have the time to do it. Or I cannot travel to another center and do it. Or say that to hiring a exercise person, a professional to do exercise is very costly. All these are there. But then there should be some way to overcome these objections. Objections are always there. Some of these objections will be mentioned, some of them will not be mentioned. So it is not easy even for prescribing exercises to people who have disability or who are in the palliative care system. It's not easy. The moment you start saying even a breathing exercise, you would say that last time I did breathing exercise, I had an asthma, or I had a cough and I had a sneezing. So another doctor said, don't do that exercise. This would be the standard barrier to any type of intervention. It need not be exercise. Anything that you ask the client to do will be resisted by such things. So therefore, it is not a game between you and the client. You'll have to take up another strategy to come back to the exercise once again. So that's how you do. Now, imagine that the client is bedridden. Quite often we find people who are bedridden. Now, what are the problems with bedriddenness? It's a major issue. Even if you do not have a disease, let us say senior citizen, for example, is completely lying down, has a lot of problems. Simply by lying down, you get into a lot of problems. Your joints become stiff. You have abnormal positions, abnormal postures. You get deformities and contractures. You will invariably get pressure sores, and you may have malnutrition, because if you become deconditioned due to inactivity, your food intake will come down, and then you will be choosing certain types of food, and that will cause micronutrient deficiency. And if you have micronutrient deficiency, you will have anemia. If you have anemia, you will have low protein metabolism will be affected. It goes on like that. It becomes a cascade of events, and finally things will be very bad. And malnutrition and bedriddenness can also cause water starvation. And the changes of water metabolism is quite common among these people. Then there's bowel and bladder dysfunction, repeated infection. One of the most important things is sensory deprivation. So any person who is staying in a room doesn't go out. It need not be bedriddenness. Even if you are confined into, like, for example, if you remember the COVID situation, lockdown situation, many people were simply shut indoors. They never went out. Now there's a lot of information about literature about people who have been staying indoors during the COVID times. Now, this is extremely important for us to read and understand, and then apply this knowledge to rehabilitative situations in palliative care. Anybody who is confined to a small space, whether it is a room or 2 rooms or 3 rooms in a given space, and doesn't go out, suffers from what is called a sensory deprivation. This is for the same reason that we don't like the jail, for example. If you give me an option, why don't you stay in jail for 1 year? Because everything is taken care of, your food is taken care of, your shelter is taken care of, you don't have to work, everything, and the medical, if you are sick, that also is taken care of. But you don't like them, is it not? You don't like that, even if you get that offer, nobody will accept it. Why don't you accept it? Because it's a sensorily depriving situation. So sensory deprivation has a lot of impact upon different levels of our life. And one of the important things that COVID taught us was to analyze how sensory deprivation causes harm to people. So they may have a psychological problem. They go into psychiatric issues. They have indulgent deliberate self-harm, or they have metabolic problems. So all these things happen in sensory deprivation. And you should know that all people in palliative care who require rehabilitation will have varying levels of sensory deprivation, which we need to address. Similarly, the other things, higher stress hormones and psychological dysfunction. You can also add other things that you come across. These are some of the list of things that I have found, but there will be a lot of other things. Lack of care, lack of connectedness with family or friends, lack of hobbies or getting involved with the social or music or dance or things like that. These are all other things. But if you list down all these problems of confined living, then you will know how to address them. That's the point that I. Of course, you need to plan how you can exercise them within their stations. These are some of the pictures that you can very easily do without requiring a professional support. How you can enable the client to do some of these exercises themselves. Yeah. Of course, look at all these things. Ankle and foot are very extremely important, because one of the key issues in inactivity, immobility is DVT. So, yeah, you know what how physiotherapy helps people. It is extremely important. It gives you a bouquet of advantages to do physiotherapy. So you need to help clients to do that. Of course, chest physiotherapy is another important thing that you have to do. You have to do the muscle re-education of muscles. You need to have the supplementary accessory muscles of respiration, abdominals, the upper limb muscles. All these things are important. Yeah, I think I need not spend time on all these things. Yeah, interestingly, if you have spinal cord injuries, the incidence of spinal cord injury, the incidence of pressure ulcer is very high, about 25%. And in 1 year, at least 20% of people will have some sort of a pressure ulcer. So pressure ulcer is one of the killing diseases that such people have. So when I say spinal cord injury, it's not confined to spinal cord injury. Any type of debilitating disease will result in pressure ulcers. And pressure ulcers are major diseases, because today we understand pressure ulcer not simply an ulcer that has occurred due to pressure. We also look at it from a metabolic point of view. So many people with chronic pressure ulcers have altered metabolism. Their liver metabolism would have changed. Their albumin globulin ratio would change, and then they may not reverse at all. So they will have permanent changes in the metabolic system, metabolic levels, and they slowly go down, unless, of course, their protein metabolism is specifically targeted. It becomes a problem. So therefore, pressure ulcer is extremely important. For even if it's the smallest pressure ulcer, take it very seriously. So these are the sites where you have the pressure ulcer. I don't know where I am going out of time. Yeah. Yeah, these are the stages of pressure ulcers. Stage 1, you catch the pressure ulcers as stage 1. So because after stage 2, these are very resistant to treatment. A stage 1 ulcer can be reversed. A stage 2 can be managed. From stage 2, it gets complicated, because the management is extremely difficult. So it requires a lot of professional time. It gets a lot of many different professionals will have to come, and it also demands a lot of critical interventions. These are stage 1. You can just look at the stage 1. Remember how stage one looks like and stage 2 look like. Memorize this picture. I can share these slides to the Palliative India, so you can get them. So at least you can learn this. Yeah. The other thing is, in order to assist anybody with rehabilitation, you have to know what are the pressure points. Pressure points will go on changing depending on the position that you have. A person who is sitting has different set of pressure points. A person who is lying down has another set of pressure points. Now, these pressure points will add to certain type of loading when you have. Now, this is another thing. These are assistive devices. Now, an assistive device can be a simple thing like a specs, the glasses, a pair of glasses are also an assistive device. A shoe is an assistive device. Please do not think that only an orthosis is an assistive device. No, anybody who is using a specs should have an assistive device. Now, assistive devices are important for two things. One, there's a general belief that people should not be using assistive device if possible. That is not correct. And I have heard many people asking the elderly people not to use assistive device if it's possible, because you will become used to it or you will become addicted to it. Actually, one of the principles of assistive devices is to make the person used to it, be used to it. It is just like you are using your pair of specs. You are used to it. If I say that you will become addicted to the specs, now remove your specs and start reading by yourself, your life will go haywire, is not. So it is not like assistive devices are to be sparingly used. Assistive devices definitely improves the quality of living. So this is one of the mechanisms by which assistive devices are actually a gift of science, and they have to be used as frequently, as profusely as possible, as long as it changes the quality of life. If the person can walk faster, if a person can walk with more competence, if a person can move from one room to another without the risk of falling, please ask the client to use the assistive device, and never come out of the get into the feeling that assistive devices are bad and a person has to do by himself or herself. I'm saying this because I'm hearing this from many places. Even the relatives of patients complain that the old man is actually always using a walker, where he can walk. You can actually walk without a walker, but he's still using a walker. I tell them that, well, it's a question of confidence, isn't it? It's a question of confidence that he or she has. So if you're more confident with a walker, yes, why not? You have to look at assistive devices not only as something that assists you, you have to look at assistive devices as a gift by which you can change your quality of life to another level. Now, how do you fit a mobility device? So this is the measurements that you have to, you have to, from the ground, you measure up to the wrist, and then take the height. That is the level at which all assistive devices will operate. So you also have to look at the angle here. So draw a straight line along the forearm, draw a line along the wrist, and what the angle that segments this here will be something like 30 degrees, not more than that. So that should be the way mobility devices are. Now, these devices are the basic level of assistive devices. These are the common things that you actually see. But today's assistive devices are much more than what you actually see, because today you have intelligent devices. Many people across the world are actually using highly intelligent devices, and if possible, you should have to go into that. So you have intelligent wheelchair today, which can navigate by itself, and it can be programmed through a GPS. So if I have an intelligent wheelchair which runs on a motor, I can put myself on the wheelchair, plan with the GPO that I have to go to the railway station. The wheelchair will take me to the railway station, and it will find obstacles and stop there. So such wheelchairs are now possible. Such wheelchairs are indeed coming. So these are the wheelchairs of future, and we are just around the corner when these wheelchairs become popular, because with AI coming in, many of the equipment that we used to find in the past are becoming robotically assisted. Now you have other set of devices which are not exactly called as assistive devices, but as orthoses. For example, you have the AFO. I'm sure all of you know the AFO, or the hand splints, which improve the function of the hand. These are also have to be used as often as possible. Today, they come in very good shapes and sizes, because plastics are available in plenty. thermolabile plastics are available. So you can actually, an intelligent client can plan an orthosis by himself or herself. So previously you need a competent orthotist to manufacture one. Perhaps for an AFO you still need, but for many hand orthoses with thermolabile plastics, well, the client might be able to do it himself or herself. Even for AFO, for walking, a person who walks better with AFO should be encouraged to use the AFO. Now, what are the advantages of an AFO? Number one, the AFO enables you to walk more. Second, the AFO will enable to walk as normally as possible. So AFO enables you to walk as normally as possible. Now the AFO also enables you to have less of energy expenditure. So therefore, that is why this becomes very important. Similarly, many people do not like to use a higher order orthosis like HKFO. Many people don't, even though technically they can use it, they are not being used. They are not very popular. And in palliative care setting, I don't think there's a role for an HKFO or KAFO. Why? Because the donning and doffing time, the time which you have to spend for wearing it and taking it out is tremendous. So the pressure on time would be tremendous. So you need somebody to do it on the patient. So therefore, if a person can walk only with an HKFO, well, maybe HKFO can be used for a therapeutic walking. All the other requirement of mobility should be done by a wheelchair. So and today wheelchairs are available. Plenty of excellent wheelchairs are now available, and those are the things that you have to plan it out as time goes on. Yeah, the other thing that I would want to say is that you have technologically adapted devices today. One thing which I said was intelligent devices, wheelchairs. Similarly, you can even have an intelligent cane for Parkinson's disease. They can warn you when you lose balance and you are about to fall. It gives you a sort of a warning. Or you can have devices where which will help you to find an obstacle. You can keep something like a torch or a cell phone, and then when you walk, if there's an obstacle in front, it will give you a beep or a vibration sensation on the palm. So this is also helpful for people who are visually impaired or auditorily impaired. So these are impairment related devices which are very common. So therefore, today you will find that people with disability can have a host of devices to help themselves. Now, there is another set of devices which are important for people in palliation, for rehabilitation. They are actually gaming devices. They are basically game devices, which can, the lowest level of game devices can be, let us say, the Sony games can be loaded on a computer, which the person can go and play. How are they important? Because they improve the cognitive, the cognition of people by actually strategizing, planning, and executing a game. You create the hand coordination, eye-hand coordination, or the thinking ability, or the ability to strategize. Now, this is very important for people who are slowly getting demented, or people who have, let us say, early Parkinson's disease, or even recovering from stroke or cognitive dysfunction. So this is another area that we need to look at when we come to assistive devices. The other area which is important is this is also another type of measurement. The other area which is important is how do you change the living environment? How do you redesign the living environment to help people with disability? Now in the West, there are plenty of check areas where you can find out from just going to the GPS or the web, whether a particular hotel or a public park is accessible to a particular type of disability or not. But in India, these are not at the present time available. But on the other hand, Government of India has brought on a publication now. I think this is an important publication. I would request all of you to sort of this. Let us see, it is opening. It's an interesting document by the Government of India, and yeah, can you see that?
No, sir, it has not opened it.
Well, it's an 85-page document. It contains guidelines and space standards for barrier-free built environment for people with disability and elderly persons. Okay, let me see. I can.
Now it's showing something, sir.
My cursor is missing.
Sir, or else we can share this link to our WhatsApp groups, so they can.
Yeah, it's a big document actually. Maybe I'll stop this and then go back to.
Yes, sir, now it has opened, sir.
Just come. Okay. Now, yeah, this is a government. It's a nicely made document. It answers most of our. The point is, I cannot see that. My cursor is missing. You got the title, is it not?
Yes, sir. Yes, sir.
Is it moving?
No, sir, not moving. It's showing the first page, sir, guidelines and space standards for barrier-free built environment for disabled and elderly persons.
Is it moving now?
Yes, sir, now it's moving, sir.
Okay, so this is the preamble. Okay, now this it contains all the. So look at the contents of this. So it contains a lot of things. It contains types of disabilities. Then it classifies buildings into various types of buildings. Then whether how much of access is provided. Then it also looks at the residential buildings, auditoriums, parks, restaurants, railway stations, and certain models. So this is a very important document for all of us, and it also tells you how to put the logo. If a non-ambulatory patient client can come, this will be the logo, the upper one. Or semi-ambulatory will have this type of a logo. So each logo means certain type of access. So that way, this is a nice document. Of course, all nice documents, as you know, can be improved after a period of time. So when you start using it, so this is how each person will have to work. It also shows you how where should you keep the switch, where should you keep the with the grasp bar. So look at the maximum reach will be here. So that is where you have to keep. That is the 120 centimeters. So like that. So yeah, 1,200 millimeters. So yeah, it gives you a lot of such details. So this will be a document which I think you should seriously consider downloading and reading. I'll send it to you anyway. Please share it among all of you. So now how to construct a wheelchair for a ramp for a wheelchair user, how to have a walkway for a person using crutches, how to have a walkway for a person who has a visual problem or a hearing problem. So if you think of it, there are things which we think we know about all these things, but some of them you need the calculation. So that way it's important. So, and you have lot of diagrams how things can be arranged. Of course, these things are documented in India. However, you don't find that this can be implemented in India, because most of our roads are transport roads, are even are not designed for even for normal, so-called normal people, and most of our cities are designed not for older people, or they're designed only for the younger people. In fact, there's a major complaint that the Indian cities are designed for a healthy male adult, not even for a female. So this is a big problem. You'll find that the facility for women are missing in many of the so-called good Indian cities. So it's a male-oriented, power-designed type of city that we have. So who will change it? Things will change only when people demand such changes. So these are at the idea level. Of course, we can start thinking of such changes in our institutions or our houses. So how many people today know about the ramp? Almost everybody knows about the ramp. How many people would decide to have a ramp in one's own house? Well, practically nobody. So therefore, this type of knowledge and pragmatizing this knowledge are two different things. Similarly, we meet lots and lots of people who fall in their own houses and die. For example, falling in the house and dying is a very common thing in India. If you look at the number of fractures in India, fracture of the hip in India, you'll find that they've all fallen in the house, their own house. 85% of the hip fractures occur in one's own house, and they were all preventable. They happen because they go to a toilet which contains water splash, or they go to a toilet and turn around because there's no light, they fall, or they have a small vertigo and then they fall because there's the flooring is too soft and too smooth, glazed tiles, etc. Then who put them there? We ourselves put them there, and we trip and fall on that. And a fracture of the hip is actually a killing disease. Out of the many people who have fractured hip and survive, they have a very poor quality of life, and they die early. So their life expectancy falls significantly after the. Therefore, the question is, how many people are willing to change it? That is where the question comes. The question is important. So thinking of rehabilitation, I would say that these are important not only from a purely rehabilitative point of view. It's important for the so-called professionals that we are. We ourselves should be able to change. Similarly, I have visited a lot of houses where the bathroom door, toilet door is smaller than what can be accommodated by a wheelchair. I have asked them, don't you know that a wheelchair requires at least 82 centimeters width? They know. But then they say, oh, yeah, finally, this is how we made it. We are sorry, we cannot do anything. We cannot change it now. Yeah, this is how it is. So therefore, these are not questions of knowledge. These are questions of attitude and internalizing our own difficulty. Because we should know that rehabilitation helps not only the client, not only the patient, not only in palliative care. It helps every one of us. If I understand rehabilitation and practices rehabilitation in my life, I myself will get the benefit of it. Similarly, each one of you, if you put a little bit of rehabilitation in your life, it helps you. So rehabilitation, it makes sense in applying rehabilitation to daily living. So for every one of us, not only for the client. For client, it is different, but for every one of us, it's important. So this is the Government of India document. So it gives everything in a scientific manner. You know how to build a ramp, how to organize it, how to turn, all these things are written down. But the only point is that if you go to an institution or in a public place, you will not be able to apply this. That is because the design space or the attitude of people who design it are different. They resist it. And perhaps it may take another 20 years of time to do it. Now, I will share this document because it's a very important document. So maybe I'll stop here because I can take a few questions if you want. So yeah, that's all about rehabilitation. Thank you.
Thank you, sir. Thank you very much for that informative and fruitful session. And it's time for the doubts clearance or any suggestions on this session. So I request our participants to come up the sessions and the doubts as sir is available. Actually, we are having a case presentation after this this one. And if you're not if you don't have any doubts to ask now, we'll move on to the presentation, and after that we can discuss. Yes, sir, Kumarvel, sir. Sir, voice is breaking, sir. Not able to hear.
Hello, sir. I have one doubt regarding functional electric stimulation. Hello. Now it is not.
Yes.
Can I ask? Hello. Hello.
Oh, yeah. I'm listening.
Yes, sir. Sorry, I want to know regarding. Yes, sir. Functional electrical stimulation in the upper motor neuron lesion in foot drop cases like that. So, how much it is helpful for to improving the functions?
Yeah,
that is one of my questions. Sir.
Yeah. Now, FES can be used only in upper motor neuron lesions because for FES to function, you require the peripheral root and the nerve intact. So, yeah. So that means ideally this is suited for in the lower limb. Lower limb it is suitable for the foot drop, either from stroke or from high level of paraplegia or quadriplegia. In this situation, or an upper motor neuron lesion coming from emanating from acylgomyelia or multiple sclerosis. Now, all these people you can try it. Now, it's a simple system where you actually stimulate the by a radio frequency. You stimulate the common peroneal nerve and then create a dorsiflexion. So the actual trigger comes from on the heel off. So there will be a small sort of a switch in the orthosis. The moment you do the heel off, the switch becomes activated. And then that takes a sensation to takes the current to a receiver that you can keep in the belt or somewhere, waist somewhere. Then from there it is connected to the fibular head, where a small shock is given to the lateral popliteal nerve through a radio frequency transmitter. So that's a typical FES system. So it is working very well. And previously, this is not a new concept basically. It is a concept that was there from 1980s. But the problem was that the equipment was extremely expensive at that time. Today it is becoming more and more cheap, and lots of people are now doing work on simplifying this. So today simple devices are now available. I think the cost has now come to something like 20,000 or 30,000 rupees. So 25,000 rupees will be a very good thing because instead of an orthosis, you can use it. A good quality orthosis is now costing about 6,000 rupees. So something like 25,000 rupees is not because you can almost have a normal gait. But then, having said that, other FES in other areas, like for example, deglutition or the upper limb, are more complicated because the upper limb or FES systems are more complex because the muscle synchrony are different. Because in the lower limb, it's only the dorsiflexion function that you require, and that can be easily achieved. Traditionally, it can be easily achieved. There are some Indian companies manufacturing the product, but the price I think is something like 70,000 rupees, 50 to 70.
Okay, sir. Thank you, sir. Thank you very much, sir.
If anybody else wants to ask something, you can ask now, or else we can move to the case presentation. Sir, can we move to the case presentation, sir? Yes, okay, today, so we'll be having a case presentation presented by Mr. Abhilash SK. So over to you, Abhilash, for the case presentation, and I welcome Abhilash for that. Abhilash, you are muted.
Thank you for the opportunity. I can audible for all?
Yes, you are
Hello?
audible. Yes, you are audible.
Yes. Yeah. So thank you for an opportunity to give me to present a case presentation here. So I am going to my case. Actually, this case is a patient with 59 years old. His name actually Fahad is a male. So he got right CVA with ischemic stroke. And he has left hemiparesis actually. He has left-sided weakness is there. His present complications are the left-sided weakness, then diabetic mellitus, dyslipidemia, hypertension, and moreover he is a bipolar patient also. Can you move to the next slide? Yeah. The history of illness actually this patient is a prisoner. He was a prisoner. In 2018, the patient admitted in the hospital here, King Khalid Hospital, with left-sided weakness and aspiration pneumonia. By the time of admission, he was very restless during the hospital stay. Even the record, it's mentioned, he was not ready to lie down his bed. He was very restless. He was, I don't know, because maybe because of the bipolar issue, he was very restless that time. Then after the initial stroke management from there, the patient is transferred to another center. It's for the rehabilitation. From there, after 6 months, he stayed. The 6 months he stayed in that institution. Then he just transferred to our hospital for the further rehabilitation. Actually, then there is no. The main issue for this patient is there is no relative for him to take care during the hospital stay. That is the main problem he is suffering. Actually, by the time maybe every 2 months, 3 months, once in every 2 months, 3 months, somebody will visit him and they will go. That's the present situation. The next slide, please. Then by examination, patient has some power, at least grade 3 power in the upper limb and grade 4 power in the lower limb. Patient can able to walk with minimal support. During our sessions, is walking with support only. As this said before, is using a cane and he is walking, but he needs some assistance. Then the range of motion, he left side there is moderate limitation present, even both upper limb and lower limb. The pain, as per the visual analog scale, is the scale rate is 6, pain ratio is 6. Then functionally is assisted in all ADL activities, even for the feeding, even for the clothing, even for the dressing, sitting, from transferring to bed, and self-hygiene, even the self-hygiene, he needs some assistance. That's a present condition, present ADL status of this patient. The next slide, please. So the present treatment, actually patient is from the medical side, patient is receiving the diabetic management, the hypertensive management, and hyperlipidemia management patient is receiving. Then the physical therapy point of view, we are giving him progressive assisted exercise, then mild to moderate stretching for his contractures, and some weight bearing exercise for his limb, gait training. These are the things we are giving according to the physical therapy point of view. The next slide. The main thing, actually, as I said before, patient has a psychological issue. He has a mood disorder is there. Some days only he will accept the treatment. Most of the day he is ready to do his daily exercise sessions, and the thing is, he don't want anything. He's totally in an isolated state. What he's saying is, why I should walk? Nobody is here for me to take care. Nobody is there. If we are going for the treatment, means what he is saying is, see, at least you can do whatever you want. See, you just compare me. I cannot do anything. I'm in the bed. If I want to walk, I need someone to help me. Then see, my family, they don't want me. He's saying he's worried about his family, and this is the main concern of him. And he's little bit violent also. In between the days, he's a little bit violent also. Even when the nurses and the others, they're going that time, his character is very violent in that time. Sometimes he's making some issues with other not only other healthcare profession, or with all, even the doctors, physical therapists, all is making issues. That's the main issue actually. The next slide, please. The current medication, patient is receiving warfarin, lactulose, atorvastatin, valsartan, and Rantac. This is the current medical medication he is receiving. The next slide, please. Yeah, the main concern of the patient, the physical point of view, the left hemiparesis, inability of walking. Even though he is walking with assistance, but inability, he is not independent. That is the physical concern. Then the other concern, psychologically, the behavior problem and the mood disorder. His main worry is his family. Nobody is ready to come. I don't know, maybe he was in the prison before. That's why nobody is there to visit him. And nobody is from the family side, nobody is willing to come and talk with him. That is very important. No, actually, not only for all concerned, all people concerned, the family support is very important. So he's missing that component. Maybe because of this problem, he is very psychologically, he's very weak. And even though he is getting some psychological counseling in between, actually in our hospital we don't have any psychological consultation. For the psychological consultation, we are bringing him to some other centers, and in between he is getting the psychological consultation. Then the socioeconomic, he don't have any economic support. That's the main thing. He don't have any single money with him. And even for the food from the outside, sometimes he's asking the others to, can you buy these things for me, and can you buy these things for me. Even our staffs, he's asking. This is his socio-economic concern. Then the spiritual concern, actually this patient, he is from Saudi Arabia. He is the most of the people there here they are very spiritual concern is very well, but for him there is no spiritual concern. If he asks about the spiritual concern, he's asking, why I should believe in this concern? No, because I don't have anything. That's his worry. These are his main concerns. The next slide, please. Summary is 59-year-old male patient with CVA, left-sided hemiplegia with physical, mental, and social spiritual issues. Next slide, please. So, discussion point: what we can done for providing the total care of this patient. The second one, how to improve the quality of the patient as a palliative care team. Then the third one, how to improve the communication with him. Then the fourth one, what are the other mental and vocational rehabilitation that we can done for this patient. This is my actually discussion questions. So I'm expecting all from the team to get suggestions.
Thank you, Abhilash. Thank you for that wonderful presentation. And these are the discussion points from Mr. Abhilash, and I request our participants to come up with their ideas for this discussion points and this patient. And lastly, we can get out to Nandakumar sir for his suggestions and comments on this patient. So first, I request our participants to come up with some ideas. These are his discussion points. What can be done for providing total care for this patient, then how to improve the quality of life this patient as a palliative care team, then how to improve the communication with him, and what are the other mental and vocational rehabilitation that can be done for this patient. So I request all of our participants to come up with your suggestions either in our chat box, or if you can unmute yourself and speak up. As Ms. Reshma chat put on the chat box that psychological consultation has to be done for this patient, as of course as a palliative care team, as a concept of palliative care is a total care, and psychological is also a main concern on that. As he is also having some bipolar disorder, he has to get some the consultation of some good psychologist or psychologist, so that we can improve his this bipolar mood disorder. Then what else we can be done for this patient?
Sir, can I ask you? Hello.
Yes, sir, go on.
Sir, whether the pain is mobile or immobile, whether he can use walking aid or wheelchair or anything we can give for mobility purpose.
Actually, yes, sir. Actually, the patient having the cane, with the cane he is walking, but even though with the cane he needs some assistive support, then he has a wheelchair. But the thing is, it's not a it's a normal wheelchair only. It's not a motorized wheelchair. At least he needs someone to just bring him outside. That's his the main problem. Before there was a man was there. That time he was very happy, but nowadays nobody is there to bring him outside. Actually, he likes to go outside. If he is going outside and he is going somewhere, means he is very happy. After 2-3 days he will be very happy. But the main thing is he's worrying about the family. But nobody is coming to me, nobody is talking to me, nobody is giving nothing to me. See, in this situation, why I am leaving, that is main concern. And with this concern, some days he is become very angry and he is not at all cooperating with us.
Okay. Okay, thank you.
So I think that's the first thing we need to do. We have to get a psychological consultation. He needs a proper counseling, not only for him. I think we have to speak with his family. Is he married or something? Or?
No, actually, he is not married. Maybe 10 years or some, he was in the prison. That's the thing. Then from the prison itself, he got stroke. From the prison, they admitted the hospital. So from after that hospital, they transferred to other hospital. That's it. But he has brothers and sisters. Lot of brothers and sisters are there. Maybe they are worrying about that issues. No, or maybe that is the thing. That's why nobody is coming and asking about his medical condition. one brother, occasionally one brother will visit and he will give something to him and he will go. That time he will be okay, but after that sometimes no, it's quite normal. He will become more arrogant than the before.
Okay, Abhilash. So I think that's the first thing we have to do. We have to speak with both, maybe his family at least. If someone is interested in taking care of him, we need to speak with him. And as Smita Mathai ma'am said, good counseling and affection, love and care can bring him back to normal and also give the family a counseling. As we were discussing, that's a point even Smita ma'am have told. Thank you, Smita ma'am, for your suggestions. And to improve the quality of life, I think first thing we have to concentrate on his psychological factor. Then as he is walking, at least with the support, he is able to walk. So the first thing we have to consider will be the psychological factors, and making him socialize will be even more better. Like if you have any if you can do some wheelchair mobilization outside your campus, or with getting socialized with other patients and all, it will be make more beneficial to his condition. Anybody else have any suggestions on this patient? Or else we can ask to Dr. Nandakumar sir. Sir, over to you, sir, for this for your suggestions and comments on this patient, sir.
Okay, thank you, Abhilash. So, I think I'm meeting you after a long time, isn't it?
Yes, sir. Yes, sir.
Yeah, maybe we met last some 6 or 7 years ago. Yeah.
Yeah, exactly 8 years, sir. Now.
Right. Yeah, good. Yeah. No, it was a nice case to think of. Now, I'll start from here because it appears as though the primary concern here, the primary medical problem would be either the stroke or the bipolar.
The primary issue was the main thing he admitted the hospital was stroke, sir. Stroke. Because he admitted with stroke. After only he became bipolar.
Yeah. So at present he has two problems, basic two major issues. One is the stroke component, the bipolar component. Now, which side is the stroke, right or left?
Right side stroke, left side weakness. Right side stroke, left side weakness, left side plegia.
Yeah. Now, a person with a left hemiplegia means the speech is preserved. He is able to talk. Yeah. But he may have a little bit of a cognitive disorder because the left side, left hemiplegia is associated with certain types of cognitive issues. Now, having said that, the stroke part itself is not a major issue here because the upper limb is, you said it's grade 3 roughly, and the lower limb is grade 4. So such a person should be able to walk. So this person is able to walk. He should be able to walk independently because grade 4 power, and he should be able to use the upper limb for certain things. But then the dominant upper limb is normal. So you should be able to function well in the community. There should not be any problem with that. If there's a problem in his functioning in the community, then that should be, you have to find out why it is so. Because with the left hemiplegia, who has got the language function preserved, with of course a little cognitive issues, he will have a certain degree of perceptual problem, or he may have apraxia. So these are the two things which you have to work out and find out. Does he have apraxia, which puts him out of function in spite of the fact that he has got grade 3 or grade 4 power? It's something that you should look at. The second thing to look at is, does he have any sort of real cognitive issues like perception, issues of perception, like verticality or perceiving things? Does he have any such issues which prevent rehabilitation? So if these two are not there, then I think you should be able to, with intense some amount of rehabilitative care, you should be able to look after himself. He should be able to walk. He should be able to move around. Now, if he is moving around, I'm simply concentrating on the hemiplegia part of it. The question is he an ambulator or not? Now, basically, a left stroke like this should be able to ambulate. If he's not ambulating, then, as I said, perceptive disorders, apraxia should be considered. If they are not there, then you have to actually work with him and make him ambulate. Once he is ambulating, the next question is he a safe ambulator or not? There the question, the answer will be difficult because he has not only the stroke, but also he has a bipolar disorder. Now, with respect to bipolar disorder, we have to now find out whether he is optimally medicated or not. Bipolar disorders, people can live reasonably good life with a bipolar disorder if they will take medications. Now, psychological counseling is alone is not sufficient, because psychological counseling works best with people who are normal, basically normal. Bipolar disorder is a major psychiatric disease. So I think the drug optimization is very important at this point of time. Now, once you achieve that, can I ask you a question? Does he have a seizure disorder also?
No, he don't have any seizure disorder,
Okay,
sir.
fine.
But in between, he's getting chest infection and is
Yeah,
getting desaturated. That's his main issue, actually. In between, it's happening.
Yeah.
Maybe because
Okay.
he's not moving around out of the
Yeah, exactly.
the room. That maybe that's a reason. And sometimes he's aspirating because the feeding by assisted feeding. No, maybe this is the reason he's getting pneumonia in between. That's his the main issue in between he's facing.
Yeah. So that is another issue. I'll come to that after the bipolar disorder. Now, once you optimize the tablets for bipolar disorder, then comes the counseling part of it. So he can be counseled, he can be taken to functional type of improvement. Maybe a cognitive behavioral therapy would help him, along with the medications that he has to take. That I think might be able to do some change. Now, before doing both these together, I think the rehabilitation team, whoever either Abhilash or somebody along with you, should find out what are his expectations. See, whatever we do, we will not be able to achieve anything beyond his own expectation. The client's expectation cannot be outreached. So if you want to do something more, then you have to help the client to expect something more. So it is the client's target that you have to find out. You find out what is the client's target. If the client says, I will not walk at all, then I don't think you'll be able to make him walk. So you have to make him wanting to walk. Only then this can be achieved. So all achievements depending upon our dream. So unless you make the person to dream something, you will not be able to do it. So perhaps with some amount of psychiatric medication, optimizing the psychiatric medication, this might be possible, because I don't see any reason why he should not be walking at the present time if he does not have apraxia. So do a neurological assessment, then do this. The second issue that you have to very seriously consider is the pneumonia part of it. So if he is aspirating occasionally, then aspiration to a person like this can come only because of two reasons. One is the neurological deficit, so you are missing something. So do a deglutition analysis and find out if the bolus of food when you do the deglutition directly falls into the esophagus and does not spill over to that mechanism is intact or not. So that it's very easy. Most of the advanced hospitals do have a facility for video fluoroscopic analysis of the swallowing analysis. So do a swallowing analysis to make sure that it is normal. So if it is not normal, then of course you need to have management for that, because with occasional aspiration, things will be very bad. So only people who have aspirated will know how difficult it is to go through that life. And having pneumonia is not an easy task. So that is another thing. And he not only has pneumonia, he also has desaturation, which is very serious. So look after that as an issue. The third thing is give him some goal to achieve. Any person who does not have a goal to achieve, irrespective of whether you are a prisoner or not, whether you are sick or not, whether you are wanted in the family or not, as long as I want myself, there can be a goal in life. So make sure that he has some goal in life. So if you can, the patient can identify some goal, at least living for tomorrow is a good goal to start with. Then you can achieve something about it. The other question that you raised is what are the mental and vocational rehab that can be done for these patients. So that depends upon the society at large, because he does not have much support system, but he may have some support from one of them. So make use of the brother who is visiting him to spend some time with him. Or maybe you and the brother and the patient can sit together, or a psychologist or a nurse can sit together and work out something. So this type of a professional working up will throw open his aspirations, whether what is it that he is suffering from, what is it that he wants. Does he want a change in the lifestyle? Does he want to go to a house and live? Does he want some support of a family? All these things can be. Does he want good food, or does he want to get married? These are all questions that can be addressed very seriously, and I think that's how to improve the quality of life for this patient. But so in conclusion, I would say, do a good neurological assessment to make sure that the apraxia is not there. Make sure that the perceptive deficits are not significant. Then do a video fluoroscopic analysis of deglutition. Make sure that the food is not spilling over to the trachea. Then do a psychiatric consultation to make sure that the drug optimization is good, and then do the other things. That's how, these are the 4 things, and then other things that I will do. But then plan it on the basis of a goal that is set with the patient and his support system. However poor it is, there will be some support system. So thank you. That's how I see it. Thank you, Abhilash.
Thank you, sir. Thank you, sir. Thank you very much.
Thank you very much sir, for your suggestions and inputs on this patient. So I think it's time to wind up our meeting. And once again, I thank Nandakumar sir for this wonderful session. Tomorrow also we'll be having a session with sir. So thank you, sir, once again. And tomorrow also we'll be having a case presentation.